Hi, welcome to this talk on obsessive-compulsive disorder and introduction. My name is Dan Stein. I'm from the University of Cape Town. Obsessive-compulsive disorder is often shortened to OCD, and it's characterized by the presence of obsessions and/or compulsions. So a typical person might walk into my office and say that what they're experiencing is having to wash their hands over and over again. You ask them why they're doing that, then they say they don't want to spread germs, they're worried about getting sick, or perhaps they're worried about hurting someone else, infecting someone else. So obsessions then are recurrent and unwelcome thoughts, perhaps about fear of dirt or germs, but there are a few other themes that are common: fear of acting on violent or aggressive impulses, feeling overly responsible for the safety of others, religious and sexual thoughts that are abhorrent to the person experiencing them. So worrying, for example, that they might have said something blasphemous. And an inordinate concern with order and arrangement and symmetry. And in response to those kinds of intrusive thoughts, people might experience compulsions or repetitive behaviors performed in response to their obsessions or simply done in a particular way. For example, washing, cleaning, checking, touching, counting, arranging, ordering, and hoarding. So, as I said, these things are very often fall into particular kinds of categories. And if you do a factor analysis or similar kinds of statistics, you usually get a 4- or 5-dimensional model with contamination symptoms, harm-related symptoms, and things that have to do with unacceptability, symmetry symptoms, or hoarding symptoms. To meet the diagnosis clinically for obsessive-compulsive disorder, then the DSM-5 and the ICD-11, which are standard classification systems, include what's called a clinical significance criterion, as well as a diagnostic hierarchy criterion. So the clinical significance criterion would be that the symptoms are associated with a lot of distress or impairment. One has to say that because in children, for example, they might have intrusive thoughts and repetitive behaviors as part of normal development. And in terms of the diagnostic hierarchy, you want to be sure that the perceptions and compulsions are due to OCD and not perhaps some other condition, perhaps drug abuse, or perhaps a medical condition, or perhaps due to certain medications. So structured diagnostic interviews like the SCID, and there are some others, will take you through the various criteria of OCD, as well as the clinical significance criteria and the diagnostic hierarchy criteria. So, as I mentioned, you could have thoughts and rituals that aren't due to OCD. There are a number of closely related conditions that are classified in DSM-5 and ICD-11 as obsessive-compulsive related disorders. They differ slightly, and you'll see that in this slide where in the sort of orange-red, you have conditions that are in both DSM-5 and ICD-11, and in gray, you have some additional conditions that are not in DSM-5 but are in ICD-11. So ICD-11 has a more expansive notion of what these conditions are. And I suppose there's disagreement in the literature about exactly how expansive one should be. Let's walk through a couple of these. So in hypochondriasis, there's often intrusive thoughts about being ill and then having to check, perhaps going to see a doctor and get reassurance that one is not in fact ill. A similar construct is found in DSM-5, but it's found in the somatic conditions, somatic symptom conditions, rather than here. Body dysmorphic disorders, where the person has intrusive thoughts about their appearance and might have checking, looking in the mirror to see how they look. I mentioned that there are hoarding symptoms in OCD, but they've kind of been removed recently to a large extent, and because there's this new condition called hoarding disorder. It seems a little different from OCD in a number of ways. For example, there aren't usually intrusive thoughts. It's really just the behavior of collecting excessively and not discarding. And then we have a couple of other conditions that are characterized by they're focused on the bodies. They're also known as body-focused repetitive behavior disorders. That's two of them are one is trichomania, where you often pull out your hair, and the other is excoriation disorder, where you peck at your skin. And then back to ICD-11, you also have olfactory reference syndrome, which is not that common in the West, and perhaps that's why it was excluded from DSM-5, but it's pretty common in the East, or it's thought to be more common in the East, and it's about not that one looks unattractive, but that one smells bad. So one has thoughts that one is smelling bad, and one might have repetitive behaviors such as washing. And then Tourette syndrome, which is characterized by tics, is classified as a developmental disorder in DSM-5, and it certainly begins in childhood. But ICD-11 allows you to classify particular conditions in different places. And so in ICD-11, it's classified as a developmental disorder, as a neurological disorder, but also as an obsessive-compulsive disorder. And that's because, well, partly because there's repetitive behavior, but also partly because there's a close genetic and familial relationship between OCD and Tourette's. And indeed, many patients with OCD also have tics. So this slides a little bit more on the concept of what makes an obsessive-compulsive related disorder. And we've talked about some of the things here, phenomenology. So do they have repetitive thoughts and repetitive actions? Comorbidities, so they might have more, trichomania, for example, you often get comorbid skin picking disorder and the other way around. There might be more of a family history of these conditions, so suggesting genetic relationships. They might have a similar neurocircuitry to OCD. We think frontostriatal circuits involved in OCD, and they might have a similar treatment response. So in OCD, you have this unusual finding that patients respond more to serotonergic antidepressants than to noradrenergic antidepressants. In depression, you would respond to both, but in body dysmorphic disorder, there's evidence that you would again have a preferential response to serotonergic agents. So one has to be careful about not confusing OCD with other conditions, as the diagnostic hierarchy criterion tells us. And, this slide runs through a little of that in more detail. In generalized anxiety disorder, you have worries, but they concern real-life issues rather than intrusive thoughts, and there are no compulsions. In depression, you often get rumination. So a person might worry over and over again about how good they are and about how terrible the future is and how bad the past is and so on. But those are typically congruent with the person's depressed mood. And they're typically, they're not experienced as this is something kind of alien to me, foreign to me. They're egosyntonic is the word that's used. Again, in substance-related and addictive disorders, some of the sexual dysfunction disorders and impulse control disorders, there's often, for example, gambling. In gambling, you would do something over and over again, but it's often slightly pleasurable, at least at the time you're gambling, before you've experienced the loss. And so again, the word egosyntonic comes to mind. In schizophrenia spectrum and other psychotic disorders, there can again be repetitive behaviors, but these disorders are characterized by thought disorder and hallucinations and delusions. In autistic spectrum disorder, again, often repetitive behaviors, and sometimes OCD can be a comorbid condition, but the characteristic issue is difficulties in social communication or reciprocal social interactions. So generally speaking, what we do is we give a person a comprehensive assessment in order to do this. In order to really diagnose OCD, as I said, they want to see substantial distress or impairment. So one indication of that is if they're very time-consuming, taking more than an hour. As I mentioned, in body dysmorphic disorder and some of the OCD-related disorders, you also get recurrent thoughts or rituals. And again, you want to differentiate OCD from somatic disorders, somatic symptom disorders, mood and anxiety disorders. So OCD is a highly prevalent and chronic condition, typically starts early in life. A meta-analysis suggests that prevalence estimates are 1.1% for current and 1.3% for lifetime. So it's a pretty, that 1.1 over 1.3 suggests that it's pretty persistent as well as prevalent. There thought to be a couple of peaks of incidence, early onset and a little bit later, sometimes during pregnancy. Many of the cases are early onset, though. Many adults with OCD have been suffering for at least 10 years before they seek and start treatment. Some of that is due to not realizing that you have OCD. Some of that may be due to embarrassment about the symptoms, not wanting to disclose them to anyone. Women seem to be a slightly greater risk. But in the early onset group, it's predominantly males. OCD, there's considerable comorbidity as well as morbidity and a significantly reduced quality of life. The domains of quality of life that are impacted in OCD include social relationships, including its emotional and psychological components. It turns out that relatives and caregivers of people with OCD also have lower quality of life, so it really does impact the family. The effects of OCD on quality of life have been reported to be similar to those of patients with really serious mental conditions such as schizophrenia. Severity of illness, comorbid depression, and certain symptom dimensions like hoarding have been associated with decreased quality of life and increased functional impairment. And then just to point out that the cost of OCD leads to a substantial economic burden on society. And at one point in the global burden of disease studies, these were really in the top few. ENIGMA and other studies have allowed us to posit what the neural circuitry is in OCD. And this is a slide that comes out of Odile van den Heuvel's work in particular, and dividing the different corticostriatal thalamic cortical circuits into their components. So there's a sensory motor corticostriatal thalamic cortical circuit that's thought to be involved with habitual behavior. There's a dorsal cognitive circuit that may be involved in more memory and planning and emotional regulation. Frontoparietal network that might be involved in coordination of cognitive control that's coming up in some studies. A ventral cognitive STC circuit that might be involved in response inhibition, ventral motivational one that might be more involved in stimulus outcome-based motivational behavior. And finally, as we work towards treating OCD, that might be a frontal limbic circuit with fear extinction. So one of the questions, though, is, are these changes a cause that lead to OCD, or are they really a consequence of OCD? And again, Odile has done a lot of work on this. The ENIGMA papers have contributed. And it might be, hypothetically, that early phases, there are alterations within the circuits related to symptoms involving anxiety, uncertainty, and goal-directed behaviors, and that later on, the alterations in the circuits relate to symptoms involving habitual behaviors. So that's one kind of hypothesis at the moment. Just quickly, a couple of words about intervention. Clinicians think that early interventions are important because it frequently begins early and you want to try and prevent and limit it. As I mentioned, the duration of untreated OCD is really much longer than is acceptable. And so if you have early detection and intervention, you might really be able to help things along. And, I live in a low and middle income country, but when it comes to mental health, one idea is that all countries are developing. And so we need to do this kind of work throughout the globe. Cognitive behavioral therapy is recommended as the first-line psychological treatment of OCD. It's very evidence-based and involves gradual and prolonged exposure to fear-provoking stimuli and not, abstaining from a compulsive behavior while you're undergoing that exposure. So not an easy treatment, but one that's highly effective and that leads to changes in brain circuitry. You can integrate exposure and response prevention with more cognitive techniques, discussing the fear consequences and dysfunctional beliefs, and that might be easier for patients and better in for some subgroups in particular. terms of the pharmacotherapy, we use selective serotonin reuptake inhibitors. A lot of studies showing that they are helpful in OCD. These are reasonably tolerated, and we use somewhat higher doses than are used in depression for at least 8 to 12 weeks, but long-term treatment is helpful in preventing relapse. So in summary, OCD is a prevalent condition. It's important to differentiate from the OCD-related disorders and other conditions. One does that through a thorough psychiatric history and examination. Early detection and intervention for OCD is something that we would advocate for, given how impairing this condition is in terms of quality of life and given how costly it is in terms of economic costs and burden on patients, family, society. And in treatment, we use cognitive behavioral therapy, and we use selective serotonin reuptake inhibitors, or SSRIs. So thanks very much for your attention.